Good afternoon. It's good to see everyone popping on. Great to see some familiar faces. I'm so happy to have you joining us today for our spotlight on urinary issues and covering the urinary issues in Parkinson's disease. We are going to be diving in here in just a second, but I want to invite you all to go ahead and open up your chat box and give us a shout out. We're always excited to hear where people are joining us from, and I see some Floridian friends in the audience today with the Harmons. Hello guys, good to see you. So give us a shout out, let us know where you're joining us from, and in the meantime, I'm going to introduce our speaker today. With us is Erica Vitek, and you guys may have been a part of some of our other talks that Erica has joined us on. And actually, we've been doing a series with occupational therapy this month, because aside from it being Parkinson's Awareness Month, it is also Occupational Therapy Month. And so we've been featuring different conversations around that. And today we're going to be talking about urinary issues. And Erica is actually board certified in biofeedback for pelvic floor muscle dysfunction, and is board certified in pelvic rehabilitation. As well, she's also LSVT big certified and is a trainer and is on faculty with LSVT Global. So she is very well connected, as well as very educated in this area. So we're excited to have Erica. So thanks, Erica, for joining us today.
Thanks for having me.
Awesome. Well, I know that we have a lot of information to cover today, so I want to kick it off first because I know urinary issues are a common problem for Parkinson's for some people, and I wanted to find out how common they actually are, and if you could cover some of those common issues that we might see.
Sure, absolutely. Well, welcome everybody. I'm excited to be here. Thank you for hosting me for the talk today. And so when we think about urinary issues and Parkinson's, they're actually extremely common. Some reports say around 30 to 40% at the low end, but some reports, even in some recent studies, have gone all the way up to into the 70% range of individuals with Parkinson's disease experiencing urinary or bladder difficulties. And so the most common, I would say, that I see clinically is complaints of the gotta go feeling, the urgency coming on much quicker than it ever used to, as well as more frequency of urination. Hence, having more urges might cause you to go a little bit more during the day and going a lot more frequently than you ever used to. And sometimes those are at very small amounts of urine that come out when you actually go and try to go to the bathroom. Another common complaint that I hear a lot about is going a lot at nighttime. So getting up during the night, disrupting sleep, and that might be a time when the medications aren't working quite as well for mobility. For some people, they have trouble moving at night. So it can be a time that's a very risky time for falling with the low lighting situations and just being maybe on an off time of the medication if you experience kind of those on and off times with your medications. And then kind of lastly would be urinary leakage. So like if we have a couple different kinds of urinary leakage. So for example, coughing, laughing, sneezing, and a little bit kind of comes out when you have that little bit of pressure that goes down on the bladder with those efforts, as well as with urges. So when the urge comes on really quickly, having that urge create that gotta go feeling so intensively that on the way to the restroom, even adjusting clothing or getting prepared to go to the bathroom might be too much stress on the system and may cause a little bit of leakage. Some people do experience even more than just a little leakage, where their whole bladder might kind of release all the urine on the way to the restroom before even getting there. The other common term that might be talked about in regards to incontinence is called mixed incontinence. And that would be a little combination of both the urgency sensation and having a little leakage, or also in combination then with the cough sneeze kind of leakage. And occasionally people experience leakage at nighttime, and that can sometimes be overflow incontinence. I don't know if anyone else has ever experienced or heard that term before, but that's when the bladder gets really full and it kind of overflows because you haven't woken up to go to the bathroom. So those are kind of some of the main things that I would say as a good starting point for defining some of what we're talking about today.
And I know we're going to dive into some of those, but I want to ask a question about neurogenic bladder, because we've heard that term. So if we're using the term neurogenic bladder, what does that mean? And what does that mean in terms of those particular symptoms that you just mentioned?
Yeah, so neurogenic bladder is a very, very general term for anyone that has what we would call like lower urinary tract dysfunction or impairment related to a neurologic condition. So when we can have some sort of direct relationship to some sort of like, say, lesion on the brain or difficulty, obviously we have less dopamine in Parkinson, so dopamine plays a role in bladder control. And so when we have less of that chemical, or we have some sort of damage in the brain, loss of dopamine cells, or other sort of lesion in the brain, that's what it's referred to then as a neurogenic bladder. So there's some sort of neurologic type lesion or damage to the nervous system that's kind of interrupting the signal of the nerves to the bladder.
Okay. So can we dive in some of those particular symptoms, because you did an overview of them, and I'm sure that people have some interest in. I know one, we're already getting a question about urinary tract, and that's on our list of things that we definitely want to cover. So can we first talk a little bit about the nocturia, that nighttime need to get up frequently, and kind of dive into that a little bit, like why is that? Is it because their bladder is full and they just have to keep going, or what is actually going on here?
Yeah, so nocturia is an interesting subject to talk about. There's a couple different areas that we can talk about related to that. So number one is we age in general. The hormone in our body that's supposed to like lessen our urine production at night starts to diminish a little bit. And so we do tend to just generally, as we age, produce a little bit more urine at night. So when we're younger, we might produce only 10, 15% of our urine at night in comparison to 24 hours of the day. But as we get older, that starts to sneak up around 20%. And sometimes when it becomes really a problem with getting up at night, we see some of those individuals producing up to like 30 to 40% of their urine actually at nighttime. And so the reasons that we have that happen can be a variety of reasons. So just in general, like I mentioned, aging, the hormonal changes in the system, we have a hormone called an antidiuretic hormone, and that hormone is supposed to be produced more at nighttime so that we don't produce so much urine at night, and that during the day, most of our urination can occur. So that's one reason. The second reason when lying down at nighttime, what can happen is if we have any swelling in the legs or we have any difficulty with our heart, we can have more kind of pooling of fluid in the lower extremities, in the feet or in the lower body throughout the day. And what happens then, you lie down and all that fluid now has to be pumped out, like we have less swelling in the morning time, right? So now our system takes up that fluid, gets it out of our legs because now we're elevated, and then the bladder fills a little quicker at night, and then we have more evacuation of fluids at nighttime. The next issue that can happen with nocturia is if you have something called orthostatic hypotension. So that's very common in Parkinson's, and what happens with that is during the day, the body is trying to maintain a higher blood pressure. And in order to do that, we need to keep more water. So the more water that gets retained by the body during the day to keep our blood pressure raised, and that's the body kind of trying to fight against that dropping in blood pressure. So we want more water. The body just does that automatically. It tries to maintain homeostasis or like a balance, right? And so then at nighttime, now we lay down and actually our blood pressure goes up a little when we're lying down versus the standing position. So now we're lying down and the body's like, oh, the blood pressure's too high. We need to get rid of some of this water. And so then at night, the bladder will fill more because of that condition. And then we'll evacuate more urine at night because of that. And so there's a lot of different realms and reasons it can happen. And then lastly, I'll just say dopamine when we're short on it and we don't have enough of that, it doesn't help to control the bladder urges. So what happens when you have not enough dopamine is the area of the brain, the basal ganglia that's affected in Parkinson's, is supposed to basically, as the bladder's filling, it's supposed to keep the bladder relaxed as the bladder fills with urine. But when there's not enough dopamine, that communication from the basal ganglia to the bladder isn't working quite right. And it's not encouraging storage of urine. It's encouraging you to have to go more and gives that gotta go feeling a little more urgency. And so at night, maybe your bladder actually doesn't fill to those larger levels, like I was just mentioning. Maybe it's you get up and you only go a couple dribbles and you're like, why am I going only a couple dribbles? I hardly had to go. But that's also the brain bladder connection.
Wow, so there's a lot involved in that. I have heard people say that their loved one, sometimes they are surprised at how much urine they actually have at night and occasionally are incontinent. How would someone address that? And there was a question about use of a water pill and how this might impact these issues.
Yeah, definitely. So water pills, from kind of my experience, physicians tend to suggest taking that in the morning so that you don't have this happening at night because of a water pill. So I would say if you're not taking it in the morning time, maybe ask your doctor if that's something you could do. I don't ever like to switch around someone's medication schedule without having you discuss it with the physician, because there may be some other reason why they might have you taking it at a different time. But some people take more than one a day as well. So it's really important to discuss that with the doctor if we feel like the water pill is impacting that nighttime voiding. And then you just mentioned like incontinence at night and management and kind of how could we deal with that? So a couple different things. When I have people come in for therapy, which I know we were probably going to talk about as some generals as well, some recommendations, but I'll just go into some of that here, Anissa, if that's okay. So I might have someone come into therapy, tell me that they're having these large volume voids at night, or they're just going a lot at night. We don't know maybe how much is coming out. And kind of the first thing I want to know is actually how much is coming out. So that really can shape my recommendations significantly more. So I have them take home one of those measuring hats that go in the toilet, and I have them document a 24-hour urine, basically diary, like how much is coming out during the day. I can see how often, I can see how much is coming out at night. And I also like to measure urges, because what I want to do is measure, what's coming out of the bladder and how much urge did you have? So is it a little itty bit and we have strong urges, or is it a whole lot and we have strong urges? So we can kind of match those things up. And that just helps the recommendations be a little more individualized, where I can actually see what your bladder is doing, because everyone's is a little different. So what is normal? So a bladder can hold around a cup to 2 cups. 2 cups is usually about a maximum. Some people can hold a little bit more. And so the average urination should be around, say, 10 ounces, 300 cc's. And so usually that would be one way, if you don't have like a measuring hat to know, would be to count 1, 1,000, 2, 1,000, 3, 1,000, and try to get up hopefully to 10. At least. Some people will count more, and you will note that, wow, maybe that first morning void, if I haven't gotten up during the night, is much larger, things like that. So really what you want to try to shoot for is around that 10. Most people kind of fall within that 8 to 12 range, sometimes more when they count. And then that correlates with every 1,000 correlates with about an ounce. And that's the average person's urine stream speed. Of course, that can vary a little, but if you don't have something to measure it in, that's a great way to kind of estimate. And so usually during the day, I'm shooting for that 10 ounce, like 300 cc urination each time. But a lot of people with Parkinson's tend to have only like 100 or 3 ounces. That is extremely common because we're not getting that basal ganglia bladder connection real strong to inhibit or calm the bladder during storage, when the bladder is supposed to be storing the urine. And so we work on techniques to try to inhibit those urges, to try to get the bladder to respond better during the day, so that at nighttime it can be much better. And so that's one of the things that we might do to estimate whether that's normal or not. Now, the normal or average, say, urinations during the day usually is around 6 to 8. Some people say 5 to 9. So, and some of those are like include a full 24 hours. So usually we say 0 to 1 at night, 6 to 8 during the day, kind of right around there. So those are about normal frequency of going to the bathroom. Now, if incontinence is a big thing at night where leakage is happening like during sleep, what we can think about is something called fluid shifting. And I'll usually try to work with individuals on getting more fluids in during the daytime hours earlier on in the day. So trying from when you wake up until around 3:30 in the afternoon, that being the bulk of when your fluids are going in. So around 64 ounces a day, the 8 glasses, that's kind of the common recommendation. Now they're kind of saying half your body weight in ounces. And sometimes that's tolerable for people and sometimes it's not. So I usually say both of those recommendations are still fair and could be used to have your aim for fluid intake. We want to shoot for that between waking time and 3:30. And then after 3:30, having about 6 ounces with dinner, preferably water because it's the least irritating on the bladder. And then only sips for medication past that. That can really help to get the bladder to kind of retrain during the day for filling and the feeling of getting the bladder to fill and using our muscle, which we're going to talk about a little bit more, to defer urgency to try to get the bladder to be retrained during the day to cooperate better at night. The other thing is there's some management options for nighttime incontinence, which I'll just throw out there now. So there's something called the PureWick, and that's for females. And it's a kind of a pressurized suction system where you lay this external kind of catheter device. Thank you. Excellent, Anessa. Thank you. Putting that externally, and there's a kind of a suction system that goes along with that. And it really helps keep the person much more dry and the skin not from getting, aggravated or broke down from incontinence. That has been a more recent innovation for females, because for males, there's been some innovations that have been out there for a while. So the condom catheter is something that I recommend for males. Some physicians don't like the full condom catheter because it can cause skin breakdown on the penis, but there's also something called the Men's Liberty. And the Men's Liberty just covers the tip of the penis. So it's not quite as aggressive on the tissues. And so the Men's Liberty option could be a really nice one as well. My understanding is that Men's Liberty does help you work with insurance if that's something that you maybe would like to get covered. I believe condom catheters in most cases are also covered if you have a prescription from your physician.
All right, I was trying to quickly drop those links in the
Yes.
chat there so everyone can snag those. So I have a question about whether there's a difference in men and women's experience with this.
Mm-hmm. Yeah, so I think that's a really good question. When I saw that on the list, I was like, that's a really good question. I think, in regards to bladder issues, there's similarities in regards to the symptoms we've been talking about. The report from when I've looked at different studies where they've done questionnaires and asked people what their symptoms are, men and women tend to experience very similar symptoms in regards to what we've been speaking about today. However, just one note is that estrogen tends to play a role more for females in that our tissues, as we age in the pelvic area, tend to be reduced with estrogen, right? Our estrogen isn't produced as much as we get older, and menopause and postmenopause and things like that can cause kind of in what we call atrophy or thinning of the vaginal tissues. And that's very close to the urethra where urine comes out of the bladder. And so there's a lot of estrogen receptors on the urethra near the bladder. And so women might have some opportunity to use estrogen creams prescribed specifically by their doctor to help with bladder issues, specifically urinary tract infections, because women have a much shorter urethra than men. And so therefore, that urethra has closer contact with the environment and other like bacterias. And so when we're short on estrogen and the tissues are thinner, bacteria is more likely to get within that shorter urethra and get into the bladder more easily than men, and then therefore cause more difficulties with urinary tract infections. Also, if the bladder is having a hard time emptying, so urinary retention, that's called, and that is not as common in Parkinson's. Sometimes in Parkinsonisms, so atypical Parkinson's might have more difficulty with retention of urine, specifically multi-system atrophy. I don't know if anyone knows what that one is, but it's more of a Parkinsonism diagnosis. They have more difficulty with getting urine out of the bladder, and potentially more UTI issues that might come up. And then on the other side, men have a prostate, which women don't. And so prostatectomy, which is removal of the prostate for like a cancer diagnosis of the prostate, can cause more problems with incontinence after that. But the recent studies, there was one recent report that said prostatectomy isn't contraindicated in Parkinson's, meaning it doesn't necessarily worsen the outcomes in comparison to someone without Parkinson's.
We earlier had a question about whether it was unusual, and I know you mentioned how many times a person should typically go during the day, but they wanted to know, is it unusual to go to the bathroom 6 to 8 times a night?
Yes, it should be 0 to 1 times a night. So the 6 times a night, that is way too much, and we would want to address that for sure with some of the techniques that I talked about, measuring, trying to figure out why this is happening, how much is coming out each time, and what might be the causal factors, because there might be a lot of other things that could potentially contribute. Even though, and as I covered a lot of things that might cause this problem, there is actually a slew of other medical problems that cause that too, where you produce more urine at night. So it really is a team approach with a therapist that can help you kind of retrain the patterns, but also a physician could be very helpful in helping to determine if there's more of a medical cause, because 6 to 8 times a night is extreme, and that's most likely very much affecting that person's sleep. And sleep is so important for movement abilities, cognition or memory, and being able to exercise, which is so important in Parkinson's. So yeah, that is absolutely something we should address and can be addressed and can be treated. That's what's so important.
And I will note that one of the comments that came through was when you were talking about limiting, the water intake after 6 p.m. to just sips. For some people, because they have a hard time getting their pills down, they have to take a little bit more. So any like comments or suggestions in that particular situation?
Yeah, so in that case, I mean, you have to take your pills. So I totally get that. But I might sometimes suggest using something like an applesauce or pudding that we would use for maybe difficulty swallowing, but maybe we'd use it in the way that maybe it's not a difficulty swallowing, but that we want to just reduce the amount of fluid that's going in. So ease of swallowing, if it's okay to take your meds with food, because, sometimes obviously there's restrictions on that as well. So, but yes, taking it with something that you can swallow it easier with, that doesn't have as much liquid, could be of benefit. But taking meds is so important, and we could try to work out other ways potentially, maybe working with the doctor as far as timing of when that last medication is taken or things like that too, modifying the schedule with physician input. Mm-hmm.
And in terms of some incontinence, earlier there was a comment, when this person coughs, sneezes, or laughs, they have some leakage, and it's not a little, but it fills their entire incontinence pants. And is this normal? Like what might be going on there?
Yeah. So the therapy that I do, it's really related mostly to the pelvic floor. And the pelvic floor is a muscle that helps to support basically all the organs of the pelvis. So it's this kind of sling of muscle that goes from front to back, kind of forming like a hammock or a bowl shape at the base of the pelvis. And it serves as that supportive function to support the organs. It also serves the function of being like the closure ability to hold things in. It also participates in like our core stability. So we usually think of that as just our abdominals and our back, but our pelvic floor participates in that support as well. And so the pelvic floor muscle can be trained just as any other muscle of the body can be exercised to have a better reaction for those coughs, sneeze, better support when you have closure there, or can get closure there. And we would work on trying to make an individualized exercise program in order to do some strengthening with that muscle to support everything. So in the clinic, as you mentioned before, Nissa, I am certified in biofeedback for pelvic muscle dysfunction. And biofeedback is an outstanding treatment technique that is very conservative. It uses a little sensor that gets inserted either male into the anorectal area with a little sensor the size of like a pinky finger, and then into the vaginal area for women if we're dealing with bladder, but we can also use anorectal sensors for bowels as well. I know that's not our topic today, but for similar conditions with pelvic floor problems. And so using that sensor internally, it rests right on the muscle, and I can actually see live on a computer along with the person I'm working with, can see the activation of their muscle, whether they're actually using the right muscle, whether they're strong or weak, or what's actually happening. Do they have good endurance? Can they hold for long periods of time? Can we do multiple squeezes in a row? All of those things. And so all of those activations of that muscle is so important to control of when that cough happens, when that sneeze happens. We need that muscle to activate or contract or close that area so that it tightens around the urethra, the tube that exits your bladder. When it tightens there, then the urine can't be let out. All right. So the challenge that we have with Parkinson's is that the bladder might already be kind of in that little bit of an overactive state because the basal ganglia isn't telling it to be calm and relaxed. So it's kind of like almost on the ready when it's pretty full, or sometimes it's not even that full and it's on the ready to go, right? So then you cough and you add pressure from your cough onto an already kind of unstable or kind of aggravated bladder. And then it's much easier for the bladder just to be like, whoop, yep, it's the no control, okay? So what happens with leakage is basically that your muscle isn't producing as much pressure as the bladder is on the top. The bladder is producing more pressure. So the bladder wins over a weaker or less stable pelvic floor, if that makes sense.
It does. And we have had some questions about other options. They've heard of Botox injections used. Is that something that is commonly used in Parkinson's?
Yes, Botox is becoming much more common in people with Parkinson's. So it is approved for overactive bladder. And what happens is the Botox procedure would be done by either typically like a urogynecologist for females, urologist for males and females as well. And they go in with a scope and go in there with the injections of the Botox and place them throughout the bladder muscle. And what happens is it's temporary. The Botox is a toxin that temporarily kills off portions of the bladder nerves that are within the muscle. And that temporarily gives the bladder some more ability to be, say, compliant, so that it'll stretch, so that it'll allow more urine into it. But because it's temporary, those injections typically have to be repeated. And one of the side effects can be urinary retention. So it can get to the point where the bladder may not actually contract to empty. I've rarely seen that happen, but it can. And so the physician always has to tell you that that can be a side effect. And then catheterization may have to be used temporarily, which can be hard sometimes if you don't have good fine motor coordination from Parkinson's. That can be a challenge. So it's something to consider. I don't see it that often though, really at all. I see good results from Botox. And sometimes a combination of Botox and the pelvic floor therapy working on muscle strength can be a really nice combination. Like, let's calm the bladder down medically, and then let's work on the muscle to kind of make up for some of that. Also, the medications too, just in regards to medical treatment, there's a lot of medications that help the bladder, but a lot of people with Parkinson's cannot tolerate taking those medications because they cause constipation, they cause urinary retention, they cause confusion. And so there is a newer one that works on a different system that is called Vitek. And that one I'm seeing much more commonly prescribed by the physicians that I partner with because the side effects are significantly less in regards to people with Parkinson's. So that I've been seeing a lot more often.
And you mentioned catheterization. We actually had a question about the use of long-term use of a Foley catheter to solve the incontinence problem, especially at night. But what would you say about that?
Yeah, I think the tendency is not to do that if possible, only because the risk of infection is so high and there does need to be nursing care involved with that. So it would probably be something that would need to be either have a home care nurse come in to be changing it regularly, or you'd have to go into the doctor's office to have it changed regularly. I rarely see someone with a permanent catheter, Foley catheter, unless they have a bladder that like just doesn't contract at all. So that would be the bladder that has basically we call it atonic, meaning the bladder can't contract anymore. So you can't pee. And so you would get a catheter typically in that scenario. It's very rare that I see a physician ever recommend using a catheter just to manage incontinence. There's just too many risks involved with infection, and yeah, just too much there. But for men, the condom catheter, the Men's Liberty, those are nice solutions. And for females at night, that PureWick has been a really excellent innovation for females.
And there was actually a question if you need a script from the doctor for PureWick.
That's a good question. I don't know for sure. Most of the people that I've worked with that have gotten it actually had used it when they were in the hospital, and then they were able to get one for home. So I wonder if that was probably how that worked. It's such a newer device that I've been introduced to in, say, the last probably 6 months that I've had a couple people using it. But yeah, that PureWick, these companies are really good about knowing exactly what you need when you contact them, like for information. So that's a really, really great question, though. I also probably will look into that a little bit more. But yeah, I think it probably couldn't hurt, because maybe you could get some coverage with insurance as well. It's always nice to have that backup referral from your doctor.
And again, I did drop the links for that, and I'll talk to you all before we close out the program today on saving your chat so that you'll have reference to these links that we put in here later on after the program. So we're getting a couple questions about the UroLift. What is that, and does that work?
Yeah, so since I'm not a urologist, I don't want to speak too much on, and urogynecologist, and these procedures that are like the bladder lift or the sling, the mesh. There's like so many different controversies about whether that's good, bad, or not. The procedures basically are to typically support the urethra, so the tube that exits the bladder, up a little bit more to give it a little bit more support or closure so that you don't leak. So the decision to have surgery, in my personal opinion, it's a big one, because you know that things aren't always perfect, but sometimes these surgeries work really well. What I would say, just from my perspective, not being the surgeon that performs them, would be it's great to try a conservative option first. So just to try to do some pelvic floor therapy with a specialist would be a great start, so that you can be sure before you would make a big decision like surgical intervention for the pelvic area, that you would have maybe exhausted some of the conservative options. Because sometimes some simple exercises can make a huge difference in this. And using the muscle to help control the symptoms that are happening because of Parkinson's, it might not be the best to fix that with surgery per se, but instead with techniques that we can use lifelong, to help to calm this bladder down that's overactive because of the Parkinson's, if that makes sense.
Yeah, thank you. I'm going back through because we're just getting some really great questions. I know you mentioned the role of estrogen, so I'm just gonna mention that someone said that if they've had a hysterectomy, can that make a difference? And I'm just going to say if that you probably would say yes to that, and maybe if you wanted to just reiterate that.
Yeah, and the estrogen cream is not for everyone, right? So somebody might have a history of breast cancer. Someone might have a history of estrogen dependent issues in that their doctor maybe doesn't want them to have supplemental estrogen. So it's always so important to talk about that with your doctor. But estrogen creams are probably the most commonly used now because oral estrogen, meaning taking a pill for estrogen replacement, would go throughout your entire body and could affect everything, not just your urethra or the vagina, right? So these creams are very innovative in that they are directed right at that area. And it is an excellent idea to speak with your doctor about that to see if they would recommend that for you, because everyone has their own individual needs and other medical history.
And I want to just take a minute and switch gears. Well, before I do, I guess this would make a really a good question, kind of go along with some that's come through. Can you talk maybe about the relationship between OFF and urinary issues?
Sure. Yeah. So during off time, when the dopamine in the system is actually at probably its lowest, is when the bladder can become even more overactive. Because we need dopamine to calm the bladder and keep the bladder relaxed when it's filling with urine, oftentimes usually tend to be the times of the day that are more urgent or most urgent.
Great. Now I want to go to the topic of urinary tract infections. So if you could just give us kind of a general overview of, why this seems to be so common in Parkinson's, the relationship to that. And, is there a difference in men and women in how it's expressed? I know that some people don't even have the pain with urination. They don't realize that they have a UTI until maybe it gets a little worse in their system and they become a little confused. So can you just do an overview of UTIs?
Sure. So I think in general, urinary tract infections are more common with aging. I haven't necessarily seen it much more common than the aging population in people with Parkinson's per se. But as I mentioned before, it really does have to do with, in regards to male and female differences at least, is the length of the urethra is much shorter in females. And so bacteria can really enter in there much easier. And in males, it's significantly longer. So it's much more rare. So if we're not getting enough fluids during the day and we're limiting fluids because our bladder is like the gotta go feeling all the time, that is a significant risk factor right there for not getting the bladder flushed out of fluid, getting all that bacteria out of there with urination. We really should shoot for a goal of having the urine being like a lemonade color, like a light yellow color, and not dark in nature, because then we know that we're getting cleared out a little bit better. Okay, so the symptoms of a bladder infection, yeah, like you said, Anissa, are not always so obvious as we age. And so the main things to look for are the things that we look for generally would be like odor in the urine, more cloudy urine, or like a burning sensation with going to the bathroom. So those are the top things. And the other thing about urinary tract infections though is that, like you said, sometimes we just don't know that we might have one. And so even paying attention to slightest differences in color, odor, sensations is so important, and staying hydrated. And if you suspect any potential change in that, I would recommend right away asking the doctor to give a urine sample to have a test done. So they call that a urinalysis, and check out the urine at that time. And sometimes if people have kind of a recurrence of this very often, you might actually want to have that as a regular check. Maybe when you go to see, if you're already seeing a urologist, having that as a regular thing that you do when you're there, or when you see your primary. But yeah, it's a good thing to just have it checked out if you're not sure.
So can pelvic rehab help reduce urinary tract infections?
So I would say, well, one of the big things that we do, and we've been kind of talking about today, is really like change lifestyle or behavioral like modifications, we might call it, with working on like water intake and trying to figure out best ways for each individual to get the adequate amount of water in each day. So that would be one thing. We kind of coach a little bit on diet. We're not dietitians, but kind of coaching a little bit on diet and trying to make sure that getting in the required amounts of fluid throughout the day. That can be one thing that can help bladder infections. The other thing is reducing constipation. So constipation, especially in females, because of the close relationship on the pelvic floor in females being very close in nature, there's constipation involved. There's a lot more bacteria that might be present on the skin. And so that can cause more chance for bladder infections for females specifically. The other thing would be that being able to use the pelvic floor muscle correctly. So the training that we do in the therapy can help with being able to basically learn how to make sure you're letting the muscle go completely to urinate, to empty the bladder completely, which also helps prevent urinary tract infections. Also, the exercise squeezing and the contracting that we work on and getting stronger can help reduce leakage, which then might reduce pad use, because pad use also has some connection to bladder infections. And so if we can reduce pad use or reduce moisture on the skin and things like that, that can also help. So yes, we can have some effect there. And then we might instruct or give advice on, seeking out maybe estrogen cream or something like that, if the physician agrees that that would be a good option for you.
And we're getting a question on a little bit more information on the UTI test strips, like the ones that people can get at home. How accurate?
Yeah.
How helpful is it? Are they just as accurate as what you get?
I think, it's probably, fairly accurate when you see that, but I would always follow that up with the physician, because we don't want to just, automatically assume, but following that up with a physician, if you suspect that that's what's happening, and and that's a positive test, I would follow that up with a true lab test with your physician. Mm-hmm.
And I will just say that I've known cases where they've done a test strip and a person is pretty sure they have a UTI from symptoms and it came back negative. So sometimes it needs to be cultured, mm-hmm. and they'll send them out for culture. So if you're really concerned, or you as a care partner might be concerned and it doesn't come back initially as positive, they may need to do that.
Yeah, that's a really good point. And there, if you have recurring urinary tract infections, some physicians will recommend like a pure cranberry, like the cranberry pills, instead of just cranberry juice. What happens is when cranberry gets into the bladder, it prevents bacteria from attaching to the bladder wall. So that's why cranberry works to help to reduce. There's a new medication, or it's actually over the counter, called D-mannose. And D-mannose is another like very concentrated cranberry like concoction that a lot of physicians I'm seeing recommend more regularly if you have recurrent urinary tract infections. It's not something that I recommend as a therapist. I always, again, even with over-the-counter medicines, I like to just check or have the patient check with their physician as well, just to be sure that we don't have any interactions or anything.
And we were also getting a question. Hold on, I lost it. They wanted to know if it's okay to use baby powder on pads for men.
On what for men?
Mm-hmm.
And I didn't hear what you said. On what for men?
Baby powder on pads for men.
On pads, excuse me.
Mm-hmm. Mm-hmm.
Yeah, I think, for men, the tissues aren't quite as sensitive to having powders or soaps or things like that. Whereas on females, really, we almost do need moisture on the mucosal tissue. And so having that be really dry or scrubbing it a lot, that's not good for female, because actually that can even increase the bacteria that could potentially cause a UTI for females, because our mucosal tissue in the vaginal area produces good bacteria that fights off the bad. So I would say for men, it's probably a little safer to be using powders or creams. And for females, it's probably not as good of an idea. Yeah.
And there was a comment about like if a female has some rigidity issues, wiping might be a little harder. What do you think about bidets as far as helping for cleanliness?
I think bidets are excellent. That is a great supplement to being clean and to not be scrubbing so much, and it just provides a more comfortable clean for females. I think it's outstanding. I mean, even some males use them, right? Yeah. Yeah. Good.
Absolutely. Especially if you have the warm water.
Yes. Right. Right.
So I want to talk a few minutes a little bit more about the pelvic rehab. I know we're getting questions of, are there exercises that they can be doing even if they don't have access to a pelvic floor rehab specialist, or how do they find one in their area? And maybe you can kind of delve a little bit more into that.
Sure. Okay, I'll start with how to find one, and then we'll go into some ideas for exercise. So there's a couple options. Some therapists do not have any sort of specialty, say, credentials, but they still might be considered a pelvic rehab specialist. So potentially your urologist might have connection to someone like that, or even your primary. So that might be one thing if you can't find someone on the websites I'm going to mention. So there's a group, the Biofeedback Institute. Let me see, to get the full name right. Biofeedback Certification International Alliance. They changed what the letters stood for. So Biofeedback Certification International Alliance. And that group is the BCIA. And what they are is they certify individuals in biofeedback for all kinds of conditions, but specifically, like myself, certified for pelvic muscle dysfunction. And so when you're on their website, you can find someone that is certified in pelvic muscle dysfunction biofeedback when you search on their website. So that would be one place to go. And the next place to go is the Herman and Wallace Pelvic Rehabilitation Institute. And that is one of my other certifications. So there are clinicians that are certified as pelvic rehabilitation practitioners, and they have a Find a Practitioner on their website. So you can also search for someone there. The American Physical Therapy Association has a certification called the WCS. So it's a women's health certification. And they also have a search tool to find a women's health specialist. So that would be specifically someone that studied women. And we wouldn't know necessarily unless you contacted them directly if they also see men. So that might be something to look into if you do find someone. So those are kind of the three places that I would start with websites, and then also asking your physician if they have a relationship. And as far as exercises go, so usually I start off with really two basic exercises, and then I can talk about one kind of upgraded exercise that I sometimes use. Okay, so the first exercise is called a quick squeeze or a quick contraction. And what we want to think about is squeezing that pelvic floor muscle tightly with some power. Okay, so a maximal or a power kind of squeeze with that muscle. And how do we squeeze that muscle? So the muscle is, remember I was saying, like that sling of muscle, basically from your pubic bone to your tailbone, kind of forming like a hammock or a bowl shape right at the base of our pelvis. And so when we think about, say you were like in a private room or excuse me, a quiet room, and you didn't want to pass gas, okay? And so you can kind of feel how you can tighten in the back area pretty easily, hopefully. Okay, kind of thinking about tightening in the back area. No one can tell you're kind of squeezing that area closed. The rest of your body, your abdominals, your legs, your buttock kind of remain very still, and no one can tell you're holding back gas. Okay, so it's a very deep sensation right at the anal area. Now I want you to think about, if you squeeze there, can you feel it leading up into the front and contracting around the urethra, or the tube that exits your bladder? Okay, so in females, you should be able to feel it go from the anal kind of opening to the front and tightening up in front. And for men, you might even be able to see the penis or the scrotum kind of lift up when you contract from back to front. And so that first squeeze that I was talking about, we can kind of try that together, is kind of thinking about power and using a max contraction and kind of pull in and then relax. Pull in and then relax. Okay, and you should really remain very still with the rest of your body. Sometimes we use our eyebrows like we're squeezing, right? But we want to think about just squeezing at that area. Okay, so I always see the eyebrows move when someone's really concentrating. learning it, but it's kind of fun. So yeah, so that would be the first contraction. I usually recommend squeeze for about it's like 1 to 2 seconds. It's pretty fast. And then letting go for, say, 2 to 4 seconds. You got to just make sure you fully let go. Okay, so it's squeeze, let go, squeeze, let go. And you do 10 of those 3 times a day. So that one goes very quickly. Okay, the second one would be like getting some endurance. So trying to hold for a longer period of time. Say tightening that same muscle, holding for the count of 10. Okay, that's usually about where I start. Some people can only hold for 5, but I try to shoot for like 10, because we might even be able to go a little longer, and hold that for 10 while you still breathe and keep all those other muscles relaxed while you're only squeezing your pelvic floor muscle. And then you relax for the count of 10. So it's squeeze for the count of 10, relax for the count of 10. Now with the squeeze, again, make sure you breathe, but also you probably aren't going to be able to squeeze at your max, at your absolute max for that full 10, right? It's more of like a little bit of what we call sub-max. You're just squeezing maybe 75% or even 50% of your ability, because otherwise, if you squeeze at your max, you can't hold it for the whole 10, right? So if you go to the gym and you can lift, say 100 pounds, but you can only do it one time, you're not going to do that for endurance, right? That's more power. So you're going to try to hold it at that kind of just a little bit of a lower level, hold that for the count of 10, and then let it go for the count of 10. Do that 10 times, 3 times a day. So those are the 2 exercises I always start with as kind of a baseline. Now the squeeze is just as important as the relax. Like we were talking about before, the squeeze holds the urine in, but the relax is very important for letting the urine out. We got to clear that bladder out fully so that you don't get the urge too soon, like, gosh, I didn't empty my bladder. And also to prevent urinary tract infections as well. So very important to have both. And plus, if you think about your bicep, your arm muscle. If you went to the gym and to strengthen your bicep, you only went like this, but you never actually relaxed, you don't get as strong. So you really want to think about fully relax, fully squeeze, fully relax, fully squeeze. Okay. A little bit of an upgrade to that, if you're really good at that and you've tried those things already, I use something called an elevator contraction. And that would be where you squeeze your muscle to like 25% of your ability, 50, 75, and 100. And you kind of think about your pelvic floor going up the elevator. And that gets a deeper contraction to give you more strength for support of your bladder. Because the idea is that the pelvic floor gives you close, but also lifting sensation. Okay. And that's good practice to try to work on that without kicking in your abdominal muscles, because they might squish on your bladder a little. And we want to try to keep those really mainly out of it and try to use only from the bottom up.
We had a question about your thoughts on those electrical stimulation devices. And even I've seen them advertised for women, the different size, I don't know what you call them, little things
Like
they have to insert and then squeeze. Mm-hmm. Can you speak on either of those?
Yeah, so I haven't found a great one over the counter that I really love. A lot of them won't give a good recording on like the app on the phone that you can use with them. I'm not 100% convinced on those devices, but I do use a similar technique with electrical stim with a medical version of the device. So the sensor that I use for biofeedback in the clinic, there's also a home unit that you can use electrical stim with. Now, usually what happens is that when you use the stimulation, I have people work with the stimulation. So when they have the stimulation going and it's trying to help you contract your muscle, you also can contract with it and actually kind of do double duty, right? Get a little bit stronger. And really research does show that those electrical stim units work best on someone that actually doesn't have the greatest contraction. If you have a pretty good contraction, it's almost kind of like a horse apiece. Really doing it with is probably just as good as doing the exercises on your own. So sometimes you might invest in something that, it costs quite a bit of money sometimes to purchase these devices, but really doing the exercises on your own, if you can give a good quality contraction, might be just as good.
And I know we're just about done with our time, but on the flip side, someone says, I'm a male, I'm retaining urine. Are there any movements to help empty more?
Yeah, so it does depend on what the reason is for the bladder not emptying. So that would be something that I would review with a person if they came into the clinic. But urodynamics is the test that tests if the bladder is actually contracting and emptying correctly. So I don't know if this gentleman had that test, but that is very helpful to know if your bladder is actually contracting to empty. And so if you haven't had that, I would absolutely recommend getting that test if the doctor agrees that that would be a good test for you after they review your history, okay? And so emptying the bladder can be really tricky because we need both a bladder contraction, pelvic floor relaxation. We need both of those to happen simultaneously. And so what I do in the clinic is working on getting the muscle to really relax and release and open and lengthen using biofeedback to help someone see if they're doing it. Or sometimes I even use palpation. So I'm trained in kind of digitally palpating those muscles to see if they're actually like opening and relaxing. And in a male, we would palpate that in the anal area. And so it can be really important to do some relaxing. So I can go through a quick breathing technique though that I do often teach for helping to empty the bladder, and it's called 4-7-8 breathing. And actually I use this for constipation management too. So what you do is 4-7-8 breathing. You breathe in your nose for the count of 4. You hold your breath for a count of 7. And then you exhale through your mouth for the count of 8. For 8. Now, what that helps you do is just really relax the body, which is what's needed to actually urinate fully. And so that helps relax the muscle. That helps activate the correct part of your nervous system to say, okay, bladder, it's socially appropriate. Let's go ahead and empty. And just gets you kind of in the mode of being able to fully relax and release. So 4-7-8 breathing is an outstanding technique to use in so many ways, but that would be another way. There's also something called the Queen's Square. It's a bladder stimulator. It doesn't provide like an electrical current. It just provides like a vibration. And what you can do is use this just over your suprapubic, meaning above your pubic bone, on your tummy, really low, above the bone though. And you place the Queen's Square there and it's a vibration, and it can sometimes stimulate the bladder to empty a little bit more. So those are just some ideas. There's also some TENS kind. I don't know if you've heard of TENS units. They're electrical stimulation that use like a little patch on the skin. There are some techniques and placements of a TENS unit that can also help with emptying, and that can be really helpful to connect with a therapist to help you figure out what might be appropriate for you.
I'm trying to find the Queen's Square and I'm not finding it.
Okay. Yes, I
Maybe
believe.
I didn't spell it right. Is it like Queen's Square?
Queens. Yep. And let me just grab my Google here. I think it's Malcolm. Just
because I was literally pulling up like London Queen's Square. So
okay. Yep. Let me just grab that for you real quick.
And while she's doing that, I will just give you guys a little reminder of how to save your chat, because we have dropped quite a bit of good links in here. So in your chat box, if you look over to the far right, you'll see next to the little smiley face, there's 3 dots. And if you pop that box open, you'll see it says save chat. And if you save that, then all of this will save onto your computer. So you'll have access to all these links later on.
Okay, so you can find the Queen Square vibrating device at Malem Medical, M-A-L-E-M Medical.
Medical. All right, thank you, Kelly. She's already popped that up, and so
Oh,
did
thanks,
the other
Kelly.
Kelly. I have 2 Kellys that are providing that information. So thanks to both of the Kellys that are joining on the spot. So I appreciate that. So I know it's over time, and I just want to thank you. There's been a lot of really great information that you shared with us. I know that there was some questions that we didn't get to related to experience with UTI and anxiety. And if somebody is experiencing that, I would kind of reiterate, what Kelly said, or Erica, I'm sorry, said, is to talk with the physician and make sure that you are sharing all of the symptoms that your loved one might be experiencing. And so I want to thank you so much, Erica, for joining us. And in the PMD tradition, we're all going to just show you our gratitude by giving you the wave of gratitude. And thank you for this great presentation and information. Very helpful. Thank you so much.
Thank you. Thanks, you guys. Love talking to you today.
Love it. And thanks everyone for joining us. And it is going to be available in 24 to 48 hours on our website. So you can go back and review it. Thank you. Bye-bye.
Bye.